Hello, everybody. We will start in 1 minute. We will give people 1 more minute to join us. Okay, so I think we will get started because we only have 1 hour for this brown bag. My name is Anna Langer, and I'm a professor of the practice of public health in the Department of Global Health and Population, where I also lead a program called the Women in Health Initiative. And it is today my distinct pleasure to introduce my colleague, Bridget Msolomba Malewezi, who is a medical doctor, a public health practitioner, a motivational speaker, an activist, and a health columnist. She's a graduate of the University of Malawi College of Medicine and Emory University, where she completed her MPH with a focus on global health. She's currently the vice president of the Malawi chapter of Women in Global Health, as well as acting chair of the task force for the establishment of the Women Doctors Association of Malawi. She is one of the founding members and currently an executive member and chairperson of public relations and COVID public awareness for the Society of Medical Doctors Malawi. Bridget is also currently a 2021 lead fellow for promoting women in global health, a fellowship opportunity offered through the Harvard Global Health Institute and the Women in Health Initiative at HSPH. In this presentation, Bridget will share the journey of getting 2 women's organizations established in Malawi, including lessons learned, challenges, and opportunities they have faced. Bridget has done many more things during her career, and she may tell us a little bit more about her during her presentation. Welcome, Bridget.
Thank you so much, Professor Langer. Thank you all for joining. It's really exciting to share about our work. As she has mentioned, I work jointly with the Women Doctors Association as well as Women in Global Health here in Malawi, and just wanted to share of the things that we've been doing since our inception. So I'll just share my screen. I hope it's coming through.
We can see your slides very well.
Okay, perfect, great. So I think Professor Langer has done a great job of introducing me, so I won't spend too much time sharing more about myself. But the outline of my presentation today, I will be sharing, as I mentioned, I'm in Malawi, a bit of background about Malawi in case others don't know much about Malawi, but I know that a lot of people do. Some of the demographics, as well as, because this is a focus on women's organizations, just to share a little bit of context into what's happening from a gender lens in country. And then, as already mentioned, that we'll be getting into some of the aspects of how we established 2 of these organizations in global health in Malawi. So Malawi is in the sub-Saharan region of Africa. It's a landlocked country, and our neighboring countries are Tanzania in red, in yellow, Zambia in green, and Mozambique in La country. See, one of our key highlights is having that lake, the blue, that's coming along, and it's known as the warm heart of Malawi, of Africa. So that's part of our call to being. We're, as I mentioned, a small country. Our population is about 19.3 million, and that's an estimated projection. 51% female, but a very young population. 51% of our population is under the age of 15, and also a very rural population. So a majority of our population, 84%, lives in rural areas. We have a life expectancy of about 63.7 years, which obviously is low, but has improved. I think about 20 years ago, it was around the 37 years mark. So some improvements in terms of access, especially to HIV treatment, and improvements in child and maternal mortality. And some of the data there. And I think something also important in terms of access to healthcare, as you can see the last bullet point there, talking about that just under a quarter of our population lives more than 8 kilometers away from a health facility. So you can see that we have a significant proportion of that rural population living in hard to reach areas. So as I mentioned, we are talking about women's health and women in global health specifically. So I wanted to provide a little bit of a lens in terms of what that looks like from a gender perspective in country. There is some good, but also I'll share the bad and the ugly that happens in Malawi, just to set the scene for some of why these organizations were important to be established. So starting with the good, because that's always a good place to start. Here we have three pictures of prominent women in Malawi, just three as a flavor of giving a sense that there is some good happening in terms of women and women's leadership. The middle picture there is the former president of the country who ruled the country from 2012 to 2014, Dr. Joyce Banda. On the left there in the sort of judge's headgear is the current Speaker of Parliament. So she's the leader of Parliament of our National Assembly currently, Catherine Gotani Hara, and on the other side is our current Minister of Health, who is also a health professional. So there is some good that is happening in country in terms of women's leadership and women's participation across the board, and even in terms of the legal frameworks that are supporting women. As you can see, they're just looking at the different gender responsive legal frameworks, looking at things like legal and policies that are looking at violence against women, employment and marriage, including access to land and protection of women. There's quite a number of legal frameworks and laws that have been put in place. Majority of them are above 50%, either in 50%, and with some still in process of being created. So there is some good that is happening in country. And I always think it's important to highlight that not all is bad in country. There is some progress and good things that are happening, both in gender and other aspects of the country. However, as always, there is some bad. And we start with things like, and there's obviously different lens that we could look at it, but because we're focused on health, I thought I'd share just a few. For example, the first table there on your left, showing the proportion of women aged 20 to 24 years who are married. So Malawi has a very high child marriage percentage. We're actually number 8 across the world in terms of 8 highest in terms of child marriage. So you can see that 42.1% of women are married before the age of 18 in country. We also have a very high maternal mortality. And I think that's probably also reflective to the fact that we have this high teen marriage, and also then reflective of adolescent birth rates, which is at the end there, about out of every 1,000 adolescents, 137 have given birth. So that's quite high. And I think that's the bad that is happening in country. Additionally, then when we get to the really bad and the ugly, gender-based violence is very prominent and prevalent in our country. 34% of women have experienced physical violence since the age of 18. So that's those that table looking at the key findings. That's from the Malawi Demographic Health Survey. Even in terms of marital status, you can see the rise, both in terms of physical violence as well as sexual violence, with about 1 in 5 women having experienced some form of sexual violence in their lives. And also, even for the children, that another survey that looked at sexual violence against children, 1 in 5 young girls before they were turning 18 had experienced some form of sexual violence. And as you can see from that table there, which is a UNICEF report, that also affected young boys, because 1 in 7 boys have also experienced sexual violence. So quite a, as I said, there is some good, there's some bad, and definitely some ugly things that are happening in terms of gender in Malawi. But also looking at specifically global health in the country. So the table on the right is looking at the proportion of women in management. And this is not specific to health per se, but you can see there that only 15.6% of women in country are accessing and managerial positions. And you can see there's no yellow. It's not a technical glitch from your screen. I think from the survey that was done, and this is data coming from UN Women Data Hub as well. So there was a significantly low percentage, close to 0, of women in senior middle management positions. So of course, we've had some of those great positions of the president and other speakers, but I think that number is sort of an outlier compared to what is generally happening for women generally. And then as we focus in on global health in Malawi, we have the diversity of cadres and professionals in global health. We have one medical school, which is relatively young, started in, I think it's just under 30 years in existence, and has currently been able to enroll equal numbers of girls and boys into the medical school. But again, very low numbers of medical doctors coming through from that. We have 19 nursing schools, and I think the original nursing school started in around 1979. So at least a bigger pool of nurses in country, which is common in most of these settings. But we do also have some specializations and training in the whole range of global health fields, both local as well as many people do get opportunities to study abroad and return to provide sort of their expertise locally. In terms of health and women, there's very few formal groupings before we establish some of these organizations, just because I think most people do interact within their own organization or their cadres or their professions. So again, the networking is more in terms of where you work or where you live, as opposed to having a formal grouping that tries to bring those together. And what we were noticing as we're growing, as you could see, that we are a small country, but we are having a greater proportion of health professionals who are women, and a growing diversity in terms of our skill set, our expertise, and the needs that rose from there is probably the platform from which both of these organizations began. And I think that laid the foundation to why we started thinking of establishing these organizations. So as I mentioned, we will be talking about Women Doctors Association of Malawi and the Malawi chapter of Women in Global Health. And just to provide a sense of what these two are. So Women Doctors Association is a local grouping with no international affiliation. So it was really created from the ground up in terms of really conceptualizing and really thinking through how to bring women doctors together. And this conversation started around February 2020 amongst a group of female doctors, just because of the context that was happening. I think around that time, we had some issues around cases of sexual harassment for medical students, female medical students, and other factors that were leading to thinking around possibly it would be important to have a unified women doctors voice. Whereas Women in Global Health, I think many of you are also already aware of Women in Global Health, which is a global movement that was established in 2015, has a global presence and a team with various country chapters that are established across the globe, both in Africa as well as other regions of the world. So in January 2023, members of the local local leaders and women in global health had read and seen some of the work that was happening with women in global health, and they were calling for interest from any countries that wanted to set up chapters. So this is the difference between these two, in that one is an affiliate of an international global movement, and the other is more of a locally generated incentive from local participants. So I think it's always important to understand what the vision is and what the mission is for these organizations. In general, it is about bringing together women in health to work together and collaborate. There is some, as you can see, even in terms of the values and some of the objectives, that is the core of both of these organizations, is really to bring women together. But in terms of women doctors, a lot of focus on internally supporting women doctors, both in terms of professional and social, as well as bringing synergies, and really also, as you can see at the end, some advocacy for issues affecting women in society. Whereas as Women in Global Health's focus is really about leadership in global health. I think that is the general conversation around women globally. And even in terms of Women in Global Health as an entity, I think one of the key statistics that has been shared is how 75% of the health workforce is women, but only 25% are in leadership positions. So that real drive to advocate for, raise the profile, and build confidence of women to take on these leadership positions, as well as really looking at the situations and structural issues that may be affecting women to take on these roles. So how do you get started? As I said, a lot of these do have, a lot of these do have, the conversations are important, and having sort of an impetus of what is happening on the global scene as well as the local scene. So from the women doctor side, as I said, a lot of conversations and discussions were happening, different groups of women thinking, can't we come together and say something or do something or really work together to support each other in various challenges that we face? And really, I think that there had been a group that had been created in 2018, but at that time, I think maybe the timing wasn't right, the numbers weren't right. Again, as I've mentioned, because our medical school is so new that there hasn't been sort of the volumes enough to get that going. But, you know, for example, when I was in medical school, there were so few of us. I think there was like 15 girls in the whole school, which was a small school as well. We were only having intakes of 20 per class, whereas now they have an intake of about 100 per class, with about half of those being girls. So I think there's been a drive and a shift towards how many women doctors are actually available to join these groups. So we used the same WhatsApp group and tried to mobilize using different people's classes and specialties just to get them to join the group. And then, because I think everybody had their own ideas about what this grouping could be. And at that time we had no name, no formal sort of logo or anything else. So what was created was an 11-member task force of volunteers to really think through, what does that look like? What would be called? What is the point, or what is the purpose of having a grouping of women doctors together? So this 11-member task force has been really leading in terms of creating what is now known as Women Doctors Association. On the other side, as I mentioned, Women in Global Health was more of a conversation, hearing about women in global health, the global movement, and then really contacting the global team to try and form a chapter. So receiving documents and MOUs to create our local chapter and signing that MOU and discussion with the global team in terms of how that is created. So more of a global entity, and then trying to bring awareness of that movement locally, and really having things like interest meetings and really trying to bring an awareness of what this movement is. So as you can see, those differences of inside out versus outside in, and that's an interesting, that's sort of the contrast that we have for the getting started part. And in terms of moving forward, in terms of that process from the women doctor side, as I said, because it was starting from scratch with nothing on the ground. So a lot of work and research went into understanding what other women doctors groupings are available regionally and globally. Are they organizations we can affiliate to? And simple things that seem simple, but even determining what should be the name. Should it be called female or women? And we realized and learned from a lot of the other groupings available that women was more encompassing and more common, and even in terms of creating logos and so forth. So a lot of work has gone into trying to create this entity, and the task force often worked in terms of meeting, discussing, and then sharing back to the membership and having surveys. So we had a lot of like surveys in terms of trying to them to decide what should be the name, what should be the logo. So a lot of those back and forth changing and so forth. Whereas from the global Women in Global Health team side, as soon as the global team signed the MOU, there was then movement towards creating a board of advisors locally, and it was a great team, an 8-member board with very influential women in global health. And I think that led to creating some credibility in terms of what this entity is. As I said, it was an entity that was global, bringing it in locally, having this board of advisors with very powerful women across different specialties and cadres really brought in a lot of credibility to what this entity is in country. And then eventually creating an executive committee. Initially, it was mainly the founders themselves running around and doing a lot of things, but then creating a structure with the committee. And this is at the point where I joined the executive committee. So I was a member of Women in Global Health, the entity when it was formed, but then was more involved towards this point when they created the executive committee, and then creating sort of platforms, including emails and Facebook pages, just for visibility and other aspects. It's also important to understand the membership of these organizations. And as I said, from the women doctor side, very focused on women doctors. So it's only for women doctors, medical to be very specific. And so your medical degree gets you into the organization. And I think because it is has an affiliation with Malawi, you have to have some sort of affiliation. So either you're a citizen of Malawi, so whether you're based in Malawi or in diaspora, for example, or outside the country for training, as long as you're a citizen of Malawi, you can be a member of the association. And then also recognizing that there's quite a number of like foreign and expatriate doctors in country working, having some affiliation to Malawi, then we put in the registration with the local medical council and regulatory board as a way of vetting that you have some affiliation with Malawi. Our grouping is not very formalized in many sense that there is no formal application. It literally was, as I put together, trying to call people to join this WhatsApp forum. So we have a WhatsApp forum, which is 250 members strong, mainly because that's the limit under which WhatsApp puts for groups. So if it expanded, we'd get some more, but we were able to create a database in July of this year where we were able to identify 353 women doctors currently working in Malawi, and that hasn't encompassed those who are outside for training or in diaspora. So there is room for expansion in terms of our membership to grow more as more people graduate, as well as a platform for having all of these members join. Whereas Women in Global Health, as I said, is a movement and really looking for promoting and advocating for women's leadership. So recognizing that there is a role for men to play. It is all encompassing of all genders that are subscribed to the objectives of women in global health, and actually encompasses any professional and cadre in global health or interest in global health. So has a more open interest in terms of membership. The current membership is currently only women, but again, as I said, it's open to all genders and has a more formalized process of application online, and then you get added to the group and the listserv. So the current structure for both of these organizations, right now for Women in Global Health, the task force is acting in the capacity of the leadership of the organization, just because we are still in the process of finalizing our constitution and registration. We have not finalized those aspects. But what is highlighted there is the proposed structure that is indicated in the constitution, the draft constitution, where we would have an advisory board that would be voted for by members that would provide oversight and guidance, and then an executive team that would do the day-to-day running of the organization, so the management of the organization, and that would be hired positions with funding, obviously. And so there is room for potential initially still having some women doctors taking those roles, and then the general membership. So that's the hierarchy. Whereas for Women in Global Health as a chapter, obviously we have a global team that provides also some strategic, technical and financial support. And then we have the 8-member advisory board, which is in place. And these were requested to be part of the board based on their influence and their specialties. And they provide oversight and guidance as well. And then the current executive, of which I'm a member, we applied for the role and then were selected by the board. But there is a potential shift again, because there is some affiliation and constitution drafting that is happening, and we do the day-to-day running of the organization on a voluntary basis. So that's some of the differences, and then the membership is at the bottom. In terms of how these are registered, there is also a difference. So Women in Global Health is going to be affiliated to an existing university, so sort of affiliated to the Global Health Department, whereas Women Doctors Association will be registered as a trust, as a charitable organization and an entity on its own. So that's also another key difference of how it's organized. So in terms of some of the activities that we've been able to conduct as Women Doctors Association, we were able to initially, I think, as I said, one of our objectives is also to advocate for issues affecting women in society. And as we said, that gender-based violence, sexual violence is quite prominent and prevalent. And I think at the time we, last year, towards the end of the year, we conducted some demonstrations and protests. So the picture there that shows End the Violence Now is a collaboration that women doctors, along with other women's organizations in country, organized marches across 3 major cities of the country, just to really highlight and raise awareness and demand for more action towards addressing this issue. And then also we were fortunate enough that one of the local insurance companies has their own women's network that was interested in supporting women doctors specifically. So some of the pictures there include, they've sponsored us with personalized lab coats, so that picture of the doctors with those lab coats, as well as sponsoring us at the bottom there with participation to, like, for example, conferences. So this was a general doctors conference, which they sponsored, as well as supporting us with capacity building for financial literacy. And I think these are important aspects that we're trying to build for women doctors, because we're not only doctors, of course, we're also mothers and wives, and have our own sort of various things that we need to build capacity for, not just medically, but as women in general. And then for women in global health, a lot of interest and awareness raising. So a lot of sessions online to meet our board, for example. So meeting these prominent members of global health and learning a lot more about their journeys and what they've done. We've done a number of series on topical issues as well, and also participating in delegations, like, for example, the Generation Equality Forum, who are part of that delegation as well. So a lot of these online events, mainly because of COVID, has prevented us from having a lot of in-person sessions. So some of the key lessons that we've learned along the way. From the women doctors side, a lot of interest, as I said, that we were able to fill up our group pretty quickly. I think that was a blessing, because we didn't really have to do a lot of hard work to try and promote people to join us. We've also received general acceptability from the medical community, and even interest from others for us to comment on issues from a women doctor's perspective. So not much resistance from the male doctors, although sometimes they jokingly say they want to form their own male doctors association, but not any significant resistance per se. Because of the protest that we had organized, we were also involved in some national level policy platforms and dialogue, like, for example, participating in the task force, the presidential task force on rape and defilement. We've also created a network within which women doctors can network and interact with each other. And so, for example, sharing all sorts of opportunities as well. And as I mentioned already, that we've had this really important partnership with Old Mutual network that really has helped us in terms of providing some lab coats and face masks and other support, that has incentivized also some other women doctors who may not have known about us to really hear more and really be interested in being part of our group. And we were able to create our database of what we do. Whereas from the women in global health side, I think that the affiliation to a global health entity and a movement has been really beneficial in terms of getting, again, women locally to be part of a movement and contributing and participating in regional and global events, like I mentioned already, the Gender Equality Forum, for example, and also the opportunity to network beyond sort of the confines of your hospital or your ward or whatever it is that where you work, to be able to really network locally, globally as well. And then really sharing of opportunities, both in terms of speaking events, consultancies, jobs. So that forum has been helpful in terms of getting some opportunities and really encouraging each other to take on more roles. As I said, our focus is on women's leadership. And I think because it does go across different professions, that there's a collaboration across cadres and professions. So, it's not just, for example, women doctors is really just women doctors. Our diversity is mainly in terms of the specialties, the ages, and sort of where we are, whereas women in global health is a little bit more diversity in terms of having even more. We even have like journalists and people who are not specifically in health but have an interest in global health. So I think that's also a success that we've had. And as I mentioned, we also have been having these online events. Hello? Oh, okay.
Yes, please go ahead.
Okay, sure. And then in terms of our challenges, mainly as has been the case for a lot of things happening in the past 2 years, the impact of COVID. As you saw, the starting time for both of these entities was around January and February 2020. So just before COVID hit Malawi, our first cases were recorded in April. So once we had cases in country, a lot of our members were involved in the COVID frontline, both as frontline designers, but also involved in policy and sort of programming. So that affected the amount of time that a lot of our membership could dedicate to establishment activities. And we did see some sort of lull in some of those, and also prevented us from having any physical meetings. So that meant that, for example, a lot of the work that has happened for both of these entities has happened online, meetings, Zoom meetings, and so forth, instead of like really being able to bring people together as we would have done in any other situation. And also another thing that has affected both of these, although it's written differently, but both of these are relying on the voluntary services and time of the membership to establish and do a lot of the groundwork. And that obviously has affected how much time people can dedicate, because obviously have their own jobs and full-time employment. So that affects how much, you can really push and implement some of the activities that you want to conduct. Although I must commend most of the members, they're really dedicated and really take time out, used weekends and evenings to really dedicate and really put some work and progress into some of the work that is happening. From the women doctors side, I think the establishment process has been long and prolonged. And we, as I said, we started from scratch. So even in terms of creating our constitution, we drafted something because we used different global and regional sort of things that we were finding, and then presented it to a lawyer, and the lawyer said, this is wrong. So we had to start all over again. So that really sort of made us lose some momentum, but we're trying to regain that as we go along. And then funding is an issue as well, because obviously we're fortunate, as I mentioned, to have Old Mutual Network, but in terms of really trying to implement activities, you do need a little bit of funding, which we've had to then generate from internally from our membership. So even, for example, to create the constitution from the legal side, we had to internally fundraise from the members to pay the lawyer, for example. So that has an impact on how much we've been able to get done. And then from the women global health side, there's relatively low awareness. As I mentioned, we've got like 105 members, which is good, but I think there is a really big network of women in global health locally. I think it's just a matter of them understanding their ability and their eligibility to be part of this membership, and really, again, an outside entity, and really advocating for the fact that it is locally relevant and what we want to do. So those are some of the challenges we've faced. So some of the key next steps are just really working towards officially launching and finalizing some of the steps that are happening. From the women doctor side, it's finalizing our constitution, getting registered, and then launching officially, and then getting all those structures in place, and hopefully in-person activities, COVID allowing. From the Women Global Health Chapter side, again, a number of aspects that need to be put in place before the official launch, and then also really starting to do activities in line with what our objectives are for advocacy and really promoting women's leadership in global health, and then also hopefully, again, some in-person activities. And then finally, how we piece it all together, how I come into the picture as well. As I mentioned, I'm a member of both of these organizations' executive leadership. So part of the process that I'm trying to support both organizations is really looking at a proposed mentorship program that will support leadership of the organization, as well as really building up, because both of these are really looking at the professional development of women, whether they're doctors or in global health generally. And we know, as I've mentioned, we see already that we have diversity and a lot of expertise inherent in our own countries, just the ability for people to connect the dots and bring together and come together to network. So part of the project that I'll be implementing under the LEAD Fellowship is to establish and pilot a mentorship platform for both these entities, for women in global health and women doctors associations, really looking at specifically understanding the different models that could be implementing, creating one, piloting the model, and then really developing lessons learned for potential scale up. So something small, hopefully starting at the beginning of next year, and then really helping the organizations have something that they can build upon for the future of both organizations. So in conclusion, as I've shared, and as you can see, that both of these platforms provide great opportunities for professional and social interaction for women in global health, and that even though the models are different, and even in terms of having the membership that is different and engagement, that these different models can be useful, and depending on what the specific objectives are for each organization. And also then looking at having some sort of collaboration, whether it's local or regional, is really helpful in implementing your work. So whether you get a partner like a corporate partner, as we did from the Women Doctor side, or having this global entity that helps build your local networks, that's also helpful. And I think one of the key things that is coming out strongly is that while voluntary participation in establishment of these organizations is helpful, because you probably don't have enough funds, or sort of need somebody to start building the building blocks, but really exploring getting full-time employees or people who can really spend their time fully is key to sustaining and implementation of these activities for both of these organizations. So these are the acknowledgements both to Women in Global Health, both the local chapter, board, as well as the leadership, as well as from the Women Doctor side, the task force members and the legal counsel for his support, and obviously women, the membership, as well as the Harvard Global Health Institute for supporting me and both of these entities in terms of our proposed mentorship program. Thank you very much, Zikomo. Looking forward to hearing your questions and anything else that you would want to discuss. Thank you.
Thank you so much, Bridget, for a very, very interesting presentation. No wonder you were selected as a lead fellow for this year. I'm very happy you are working with us as a fellow. Now, this is open now for Q&A. There are some questions in the chat. I would encourage people who type them to say them out loud, if you don't mind. And any other person, please feel free to raise your hand. We have now approximately 24 minutes for Q&A. Farah, I think you asked some questions online. Why don't you start?
Yeah, I wanted to say thank you so much, Dr. Bridget. I really appreciate that. I already sent out a tweet. I tried to tag you on it, and I just said it was an amazing presentation, and I was thrilled to see physicians taking to the streets demanding an end to violence against women. I thought that was super inspiring. And I was just wondering if you could talk a little bit more about other women's movements or social justice movements or progressive movements that exist in Malawi. It's just really inspiring to hear your work. Thank you.
Thank you so much, Farah. Sure. So as I said, that with the women doctors, the protests were actually, we did them together with what is known as the Women Manifesto Movement. So that's a collaboration of different organizations that are looking to women's leadership and participation in like politics. We also had legal counsel, so WALREC, for example, women legal resources. So there's quite a number of different women organizations. And I think as we started to participate, for example, in the task force for rape and defilement, we were also engaging with like women judges, women lawyers. So there's quite a number of like local women-led entities that are here that are developing as well. And there's also, I think, just before we had the major protests as well, there was also protests by women in media. So I think there was a lot of this momentum from women, and it was, I mean, I think at the time there was just so many cases every day on social media of children, babies, women, girls defiled, even boys. I think, as I've mentioned, as I highlighted already, that there is quite a significant sexual violence issue in country. And I think we were really trying to raise that awareness. So there's quite a lot of movements in looking at different aspects, not only in terms of gender-based violence, but also in terms of just women's participation and empowerment, both in terms of participation, but also economic justice. Yeah.
Thank you so much. And can I just ask, are there men involved in these movements? Are there feminist men or men working with your organization to support what you're doing?
Yes. So, for example, I think that there is, like, for example, the Gender Coordination Network, and that one has all entity, also is a body that brings in whether it's male movements and men. And I think there is a recognition that there needs to be some involvement of men, especially because they're often the perpetrators, and they also have a different way of engaging other men in this conversation. So that has also been a deliberate move. Even, for example, in terms of our protests, of course, it was mainly women that showed up, but men joined us. So I think we didn't say only women come out. We said anybody who is interested in really supporting this kind of work needs to come and be involved. So that was part of the things that we were doing, really realizing that you can't polarize them completely. We need to be involving them in this conversation, and that's what we've been doing. Yeah.
Thank you so much.
Bridget. Any other questions or comments for Bridget?
I can see some of the questions in the chat.
In the chat, maybe you might want to address some of them.
Yes.
That would be perfect. Thank you.
Yeah. So I've seen one question about some of the rights or recourses that are not yet in the law. And then I threw another question in terms of the family and social structure in Malawi. Are women encouraged to join healthcare or other fields? So I'll start with the second question from, and I hope I say the name correctly, but Batul Hissam. So I think that in Malawi, like a lot of there is a movement towards encouraging girls. And I thought also why we were also thinking that as women doctors, we could be advocating for women to join medical fields. A lot of women do want to join, but I think it's been mainly nursing because that's what's been seen and more prominent. As I mentioned, that nursing has been established in country longer. I think the challenges to access for professionals are access to education. As you could see, that high rate of child marriage impacts on girls being able to go to school and progress with their education. And also, I think often, as often is the case in patriarchal societies, that where there's a boy and a girl, often then parents would prefer to promote the boy's education as opposed to the girl. But in general, I think there has been, especially as we are seeing a lot of these professional bodies of women coming out to the fore, that we are seeing more advocacy and promotion of girls to take on various roles, whether it's in health or even alternative like arts and other things. So there's a lot of movement locally to really encourage women to participate and take part and support them in education, both from the early stages, girls' education, right up to the end of being a professional. In terms of you're welcome. Thank you so much. And then the rights and recourses that are not yet in the law. I think that there's certainly, I'm not a legal expert per se, but I think some of the issues are in terms of implementation. So, and the practicality of some of the laws. So for example, some of the issues involve, I would say from like, for example, when we were engaging in the task force of rape and defilement, just looking at the definitions of how rape and even the term of defilement itself is something that is coming into the area of how that is being addressed. So while I don't have the exact list of all the gender laws, but I think that they are, as I said, there is some progress moving, including, for example, we have a specific Gender Equality Act. We have like some laws that have really looked at trying to prevent child marriage, but it's still not quite there yet. So, I think that there's a lot of movement towards putting those in place. But even, for example, other things like the termination of pregnancy, so abortion is still not legal in country, and that's something that often is seen as a sexual and reproductive health right. So those are kind of some of the aspects that are not yet in law. And so those are some of the areas that I'm aware of at the moment. And then I'll scroll down because I might be at other questions.
Yes, you have a question from Olivia, I think.
Yeah, on the reasons of high teen rate marriage. I think that, and I often tell people that in the way that our culture and our tribes are formed and the formulation of the being, there isn't really adolescence or teen period. You're a child and then you're a woman. There is like, once you get your menses, there isn't really that period of, there isn't that transition. And I think that recognition of someone being an adolescent or a teenager doesn't really exist in our cultural dynamic. So I think that really leads to the fact that a lot of families, and as you could see, our population is very rural, and our education rate, I didn't share that, but a lot of that rural population, and even in terms of some of these urban settings, that there isn't that sort of period of once a girl has had her menses, she's now a woman, and therefore for the general population, they see it as now she's ready for marriage. And that's, I think, part of the core of why that is happening. And so there is a lot of like advocacy locally to try and let people understand that there is this period, this attained period. Girls can go to school, gain an education, come back, you know, and contribute to society in a different way. But marriage is seen as a very in high regard in country. So even I often have shared stories of how even in my own family, where, you know, some of my very accomplished family members would be, you know, they're with their PhDs, but they're not looked upon with the kind of respect in family because they're not married. So marriage is held in that high regard that I think that there's a lot of work still needs to be done to really bring down that, you know, sort of the high regard for marriage, and the fact that as soon as you turn, you know, as soon as you hit your menses, you are a woman, that there's still a lot of work that needs to be done. There's a lot of work happening, and a lot of, you know, I think that we've had chiefs who've ended child, you know, sort of in their regions advocating for ending of child marriages. And also because marriages itself are often an economic benefit for families, right? Especially in those families where there's things like a bride price. So those things also affect, like, for example, families who are struggling financially would see a benefit to letting their girl get married because they'll get some financial benefits. So there's a lot of those factors that are at play in terms of why girls are getting married highly in country. Yeah.
Thank you so much, Bridget. That's very enlightening. Great presentation.
Thank you. I think I've covered all the questions in the chat.
Yeah, there is one colleague who offered to tell us a little bit about the Kenya experience.
That would be great.
Hi, Bridget. Excellent presentation, and power to you that you're trying to do two things concurrently. It's a lot, so I do appreciate the effort. I'll briefly share on the experience in this work in Kenya. In my former life before coming back for, you know, my postdoc, I was engaged in this, and it entails a lot. And I think the things I would just flag, and happy to also touch base offline. First of all is like using low-hanging fruit, and I think you've mentioned this, using men who are feminists to support that. I suppose that you have a national association for doctors, so not just like gender-based, you know, affiliation. So that can be a place to start rounding up people. So rather than having to create standalone events for the Association for Women, you can use that and sort of leverage that and create like side meetings where you can, you know, tell people we are meeting on this and this date, and we'll have a special sitting for women doctors in Malawi. So think about that. Another thing, so I remember with my experience in Kenya, I joined the Kenya Medical Women's Association, so that's what it's called, through the Kenya Medical Association, which is a national group. And that could be another way of thinking about integrating the medical students into national level activities. So sort of gives them a sneak peek into what they're coming into in the field. And so if there's a way you can advocate for a student representative within also your association, that would be a great place to create a pipeline of students who will be coming in and replacing like the older folks as they're coming out. And then think also about funding. Funding really is the crux of whether this thing succeeds or not. So at this point, you'll definitely have to do a lot of fundraising, chip in from your own pocket. Think about organizations that work with women and children, and that's usually at the advantage of women doctors, is that you have a very wide berth with to use. So I think like in Kenya, we worked with a water purifier company, and you know, just because that ties in with water and sanitation, we worked with cervical cancer company, again, because we have women and children sort of falling under women, and that's the unique niche that you have, and you can really explore that. I think finally, and this is now away from the Women's Association, thinking about women in global health, I think one thing I'll just flag early on is whether you'll be able to really address the colonial underpinnings of global health and how you're going to address that within the association. Not that I'm saying that you have to do something now, but just making it very clear that global health really has a very colonial background, and not acknowledging that will be a disservice to the team. Thank you.
Thank you so much. Those are great insights and helpful. I think, yeah, I'll definitely try and reach out as well for some more offline.
Thank you, Beatrice. Any other comments or questions for Bridget? Well, if there aren't any, I think that we can finish a few minutes early. Thank you again for a wonderful presentation and for a very engaging discussion. And we look forward to continuing our conversation throughout the year. You will be at Harvard and beyond. Thank you so much.
Thank you so much. Thank you, everyone.
Bye, everyone.